Good morning. Hello, everybody. I am Dr. Pedro Bernaldez from Seville, is in Spain. I am orthopedic surgeon in sport traumatology and an enthusiast in regenerative medicine. Thanks to Dr. Luigi Gatta for this kindly invitation in this amazing course. It's a pity because I can't stay with you, but finally I couldn't go. And I'm going to talk about the conference that is a passion of me during many years. My mind has been changing about the old room to the clinic, and in the concept we call the regenerative orthopedist, from the surgeon who adds an lesion to the physician who understands the complete process. But I would like to start about the good relation between the international regenerative medicine academic, like the Spanish and the Italian, Brazilian and England, American, and other academy. We are creating different study group. We are talking about regenerative medicine, interventional orthopedic and ultrasound guide injection that are changing our knowledge about how we can treat patient and improve the result in the lesion. Okay, I am orthopedic surgeon. My passion is surgery. I normally do two days of the week doing surgery, but I operate less and less, and I am really delighted. I have no problem with this. I have many colleagues that they're very proud to do many surgeries, and they don't want anymore about the ultrasound and regenerative medicine. I respect, but I think they will have to see this kind of conference because their mind is starting to change. The historical peak of the specialty for decades, orthopedic surgery has represented the ultimate expression of this specialty. The operating room was the definitive space for resolving major structural failures, meniscal tears, tendon ruptures, stability, advanced arthrosis, and profound deformities. For many traumatologists, the act of operate became nearly synonymous with the full exercise of the profession. It was the gold standard of the resolution. But the true advance is deciding better. We have a balance between operating more or indicate more. The clinical experience and scientific evolution revealed a clear truth. Not every visible lesion on an MRI requires surgery. This is a sentence I repeat every day. Not every structural tear explains the patient's pain. Not every radiological arthrosis justifies an intervention. Spending the acts of medicine, we have to inform the patient, explaining the lesion, managing the loads, and coordinating the return to sport are profound medical acts. We need to do these acts every day. They may lack the spectacle of surgery, but they carry an enormous impact on the final outcome. Because many injuries don't begin the day the pain appears. They gestate over months or years through altered load, strength deficit, poor recovery, systematic inflammation, or lack of patient education. And then we need to gestation of the phases before the pain appears. With the emergency of evidence-based medicine, meta-analysis, clinical guidelines, protocol, as well the clinical experience, have made it easier for us to indicate more precisely the surgical treatment in certain pathologies. The patient then can't be reduced to an image. We need to talk with him, with her, about the age and metabolic state, about the kind of sport, the activity, the patient expectation, the pain level, the functional capacity. We need to ask about the muscle strength, the mobility, the weight, the sleep quality, the psychological state and adherence, Definitely, we need to treat the whole patient. I normally say I don't treat a knee, I treat a patient. Modern musculoskeletal medicine requires a broader perspective. Only from this global vision can we justly decide if a patient needs surgery, biological treatment, rehabilitation, load control, or simple time. The therapeutic decision matrix, the traditional approach, in the primary focus, we need structural correction, the surgery as the ultimate resolution, a strictly diagnostic and planning escape, and the view of lesion is isolate mechanical failure. But the regenerative approach, we change our minds. The primary focus is a functional and biological restoration, the surgery as a component of a broader biological strategy. The consultation utility integrates diagnostic and therapeutic intervention space, and the view of lesion is a continuous process of disease repair and function. Like Dr. Sabal said, when you place the scalpel on a patient, a spiral of violence begins that we will never know when it will end. All of us, we know the typical scope in the knee, and he has a hydratus, we need a second look, and we have a contral lesion, and then we have a infection of the knee, we have to do a lavage and antibiotic, and we have a big arthrosis, and now they need a total knee replacement, and it's mobilized, and we need a revision. Okay, all of us, we know that the name of different complications in patients. That's the reason we need to measure and to be very, very quiet with the indication of the surgery. But the reason that we are treating many soft tissue with biological therapy. You can see in this case, probably 10 years ago, in a micro tears of the extensor carpus radialis brevis, I will indicate surgery, but now I indicate orthobiological. It's estimated that to learn to operate, about 5 years of training is required. To know what to operate, about 10 years, and 15 years to know what shall not be operated. And then experience has no ethical value. It's simple the name we gave to our mistakes. It shows that the future will be identical to the past, like Oscar Wilde said. Our philosophy, we have 3 reflections that I want to share with you. The first one, and the most important, the key to success is the correct indication. And this is only given to us by a proper diagnostic. Our kingdom by a good diagnostic. The second reflection, like Dr. Gregorio Marayon said, to know what a patient has, we only need a chair and time. And the third reflection, like Hippocrates said, primum non nostre. They are very simple ideas, but very, very, very important. And then we need to redefining the consultation space. We need, in the first phase, a real-time exploration, correlating the image with the exact point of pain dynamically. That's very, very important. Sometimes we see a meniscal, external meniscal tears, but the patient has no pain in that point. Otherwise, in the medial aspect of the knee. The second phase is the precision localization, evaluating tendon, muscle, ligaments, and nerves without the light. And the third phase, before the treatment space, we need to do an ultrasound guide study and intervention, acting directly on the lesion with millimeter precision. I normally say ultrasound like precision. Ultrasounds change the paradigm. The things cease to be merely a place for diagnostic. selective infiltration, hydrodilatation, nerve blocks, barbotage, and ultrasound-assisted surgery expand our possibility without aggressive procedures. And then the concept of interventional orthobiologic. We have a big arsenal with different treatments like platelet-rich plasma, bone marrow aspirate concentration, and adipose tissue that has different effects of modulate inflammation, improve pain, create a favorable environment for repair, and then we get a functional recovery. We always say those are not magic solution nor universal substitute for surgery. They are highly targeted biological instruments capable of assisting injured tissues in recovery and environment conducive to natural repair. And then the synergy over opposition. We have a surgical indication, we have a biological indication, and then the synergy is the modern synthesis, biological enhancement of surgical repairs and surgical rescue of biological failure. The key is not to pit surgery against regenerative medicine. They are not opposing wars. They are part of the same medicine. And that's the reason we create 10 years ago the SUBA protocol. The SUBA protocol is not a new invention. It's only to order different concepts like I think is the best option to treat a patient in the clinic. The SUBA is a sport, decision and diagnostic with a sport, integrating sport activity, comprehensive diagnostic, and personalized strategy. Ultrasound, ultrasound. Ultrasound is the essential tool to dynamically confirm, localize, and guide. Remember, precision. B of biologics. Interventions acting as a primary therapeutic alternative or surgical complement. And then A of arthroscopy. Is we need to do a surgery, obviously it's better doing arthroscopy. That's for lateral is called SUBA. In Spain, we call DEVA protocol. For me, are always in my mind, and I try to do in all my passions. And then that's all theory, DEVA or SUBA protocol. The protocol supersets the product. We need a precise diagnosis with ultrasound guides. We have the quality biological product. We have to manage the load management and rehabilitation. And all of this, we obtain a sustainable functional outcome. And that's the reason we create a big group. We start in 2017, almost 10 years, with different college of different specialty, not only orthopedic surgeon. We have a physiatra, rehabilitation, sport medicine. We have general medicine, internal medicine, anesthesiology with manage of the regenerative medicine. Of 15 countries in all over the world, and that's allow us to exchange the knowledge. We speak the same language, and we are always sharing clinical case, papers, course, and this is a really, really, really great idea. It's a very similar theory like Dr. Chris Centeno with his interventional orthopedics. He talked about SANS, stability, articulation, neuromuscular, and symmetry. It's very similar. The interventional orthopedic, it places more importance on the functionality of the joint or limb than on a particular X-ray or MRI. Normally, structure, it was equal function, but nowadays it's different. While surgical orthopedics believe that structure is equal to function, interventional orthopedics recognize countless studies that show that pain and loss function often doesn't correlate with how the X-ray or MRI looks. And we have, for example, For example, the long-term use of corticosteroid injection in non-inflammatory process like osteoarthritis or tendinopathy. We have demonstrated that it's a bad idea because cortisone may work in the short term but make the problem worse in the long term. The body regenerates through inflammation, and cortisone inhibits inflammation and scarring, thus interrupting the three characteristic phases of regeneration: inflammatory phases, proliferative phases, and remodeling phases. Other example, very typical, meniscal tear was the same of arthroscopy meniscectomy. Bad idea, because there are different papers who demonstrate that in a long term, probably the pain is worse than don't touch this meniscal tear uh, without block or instability, of course. Also, the same in the rotator cuff tears. We don't operate resonance because sometimes there's a high rate of failures, sometimes 30%. That's the reason we are changing our paradigms and we are treating that's different patient in our clinic. We are using ultrasound. We have 3 machines of ultrasound, and we are treating this tendinopathy in patella tendon, in gluteus medius, extensor carpi radialis, calf, fasciitis plantaris, all of this chronic disease. We are using the PRP like the first option after the first step, the rehabilitation and modified load is failure. You can visit our clinic if you are interested. We have a program, Sport Me Academy, that you can visit us. And even we can use inside our room in the surgery, we call biological augmentation. That's the reason we have suture a cuff, and at the end, we can put the PRP directly in the lesion. As you can see here. And obviously, the spinal fusion surgery. Every year are more evidence don't do so many spinal fusion surgery about the problem. Okay, and then the power of interventional biological. They are not magic solution. They are scientifically proven biological instruments to modulate inflammation, improve pain, and promote tissue repair in the injured environment. We have 3 treatments: the platelet-rich plasma, the most popular and the most used, and then stem cells derived of bone marrow aspirate or adipose tissue derivatives. That's a normal day in my clinic. You can see how we treat a posterior tibial tendon or hydrodilation of sciatic nerve. And we are using the old rule, but the indications are more strictly in true mechanical blocks, unstable traumatic injuries, reparable structural tears, or disabling advanced arthritis. Dr. Centeno make different revision about the evidence of many surgical procedures that are integrated in our clinic, and he asked about their evidence, some evidence to operate a rotator cuff or to put a total hip replacement or ACL reconstruction. And you can read this paper. It's very, very relevant because finally he conclusion is about only two surgery has real relevance and evidence about the good result. And there are the carpal tunnel release, as you can see, and the total hip arthroplastia is really amazing. We can discuss about this. Okay, conclusions. The true advance doesn't consist of operating more, but in indication better. Surgery doesn't solve all the pathology. The key to success is the correct indication and a good diagnostic. Before, we only have conservative treatment on surgery, but now we have the SUBA protocol to treat many, many patients. That's the reason I normally say now I am more tired the clinical days than the operation room days. I recommend to use the SUBA protocol, sport, ultrasound, biological, and arthroscopy. This is the paradigm shift, the difference between the traditional traumatology and the SUBA protocols. And the future of the traumatology is the modern regenerative orthopedist doesn't abandon the operating room, but no longer depend exclusively on it. Here you are the advantage of use ultrasound MCK in the clinic. We have no excuse to use ultrasound like an orthopedic surgery in the concept of regenerative orthopedic. And I can't be with you. It's obviously. Normally, I do approximately 15 ultrasound procedure or study every day. It's forbidden to have a consultation without ultrasound from now on. Okay, it's my recommendation to you. Decide better, operate less, do more medicine. Don't treat any patient with regenerative medicine if you don't have a certain diagnostic. Thank you very much. Here you are, my clinic in Seville. It's a Sport Me Medical Center. And I would like to invite to the third edition of the Spanish Academy of Regenerative Medicine, who start in 1 week. You can follow in social needs. Also, on LinkedIn, we have a very big page in LinkedIn. And also, you are invited to the sixth edition in the international course or Ortho BMCK that Dr. Luigi Gata is a usually participant, and it will be a pleasure to see you there. Thank you very much and have a good course. See you very soon.